everybody, and welcome to Health Talk. I am your host, Dr. Niru Prasad, with my background in pediatrics, emergency medicine, and urgent care. Joining us today is my guest speaker, Dr. Caroline Schnorr, and she is a breast surgical oncologist. The reason I was more determined is to have somebody from her specialties because October was a breast care awareness month. And sadly I could not get, but this is just the beginning of November.
Yep.
So Carrie, just to make myself happy, I am in pink half.
Looks great.
So Carrie, will you please give your introduction to our viewers?
Yes. So, hi, I'm Dr. Schnur. I grew up in Southeast Michigan, trained in Michigan at Michigan State University, and then had done my general surgery training in Southeast Michigan, as well as my breast surgical oncologist fellowship. And I'm currently working at a large center in the Oakland area, and truly am enjoying my experience and love my work.
Right, yeah, I know. You have such a lot of things you have done, I just could not even. I said, I will let Kitty introduce herself. So Kitty, just, tell us about this breast cancer awareness month. I know it was established in 18 something.
Yeah, so breast cancer awareness, I think the movement started more so in the 80s and 90s when screening mammograms started to become a definitive recommendation.
Yeah.
And I think it's so important for patients, even if they don't have a family history of breast cancer, to get information. And I think there's so much out there now that it triggers patients to say, hey, is this something that I should be doing? And starts that conversation with their providers.
Yeah, so that's very important to know, the awareness. What are you looking at? What makes you go, to a physician for a checkup, right?
Correct.
So why is the awareness just so important in the month of October? Is there some reason, and what was the biggest misconception you encounter about the breast cancer?
Yeah. So I found it. I was happy to see that we were presenting or doing this talk in November,
Right.
Because I think it's highlighted in October, and then maybe people don't hear about it, and then it kind of falls to the
Then
wayside.
the holiday comes and they say,
Yeah.
okay, we'll go afterwards.
Right. And, breast cancer, it's not seasonal. It happens all year round. So
Exactly,
I think following your screening recommendations by your provider, self-breast exams are very important. And then in terms of, what you should be looking for and discussing with your provider, any new changes in the breast, new masses, lumps, anything that's concerning, have that conversation with your provider.
Yeah, so basically you advise that women, they should first go to their primary care physician who will do a good breast examination. Whether there is a lump, yes or no, but it is painful in some local area, that is a point of suspicion, right? And then they will send it to mammogram, and then you are involved, right? Am I saying it right? Correct me.
Yes, no, that's usually kind of the trajectory of how a patient ends up in the breast surgical oncologist. I think it is really important, though, to highlight, you brought up some really good concerning features, patients who have palpable breast masses or changes, but not all breast cancer presents
exactly
as a change. You might not notice anything. And I think that's one of the 9.9 out of 10 times when I have a new breast cancer patient that I'm seeing for the first time in consultation, they're usually so surprised because they didn't feel anything on their exam, and it was picked up on their screening mammogram. So that's why it's so important to get your screening mammograms.
And Kitty, what are the age limits we are looking for?
So
When should they go? Like I was reading into so many journal articles, they say 40 and above age. Do you agree with me?
yeah, so I think for the caveat being, so for the general population that's at average risk, we recommend starting screening mammograms at age 40.
Age 40, okay.
However, there is a certain subset of patient populations that we would recommend to start screening more soon.
Right, yeah.
So that would be patients that have a family history, something like a
I was
first.
going to ask you, that was my next question.
Yeah.
Family history, genetics.
Exactly. I think very important knowing the family history. First degree relatives, we would consider like your mother, sister, daughter. Some of those patients we recommend starting your screening mammogram 10 years before the general population. I think it's important to note, though, everyone's screening recommendations are going to be individualized based on your history, your family history, and your risk.
Right, right.
So just having that conversation with your provider is so important.
So most important is that if you have a family history, or mother or somebody else have it in the family, then you are more cautious, right?
Yeah, I think two things. So, yes, I think you should be more cautious. One of the things that I do with patients when I'm seeing them for the first time is
Yeah.
I put their information into a risk calculator and I come up with what is your lifetime percentage of having breast cancer. Should we do supplemental screening beyond your
Right,
screening
yeah.
mammogram? But I also think just like lifestyle, healthy lifestyle, those can dovetail into it, not just the family history.
Okay, so this is the segment 2, the risk factor and the prevention we are talking about. But I have seen several patients in my clinical practice, sometimes they don't have breast symptoms, sometimes they have shoulder pain and they have chest pain, something like that.
Yeah.
And when on examination, they might just have some inflammatory area, not even a lump. So would you comment on, you give your expertise about that?
So I think, so we're talking about like what are the symptoms in terms,
Right, yeah. Besides the vague symptoms.
Yeah, so I think if you are starting to experience, again, like we were talking about earlier, any new palpable mass, nipple drainage or discharge.
I was going to ask you. I
Yeah.
have seen several of them. They will just have some discharge.
Yeah, and so discharge too can be, we say physiologically, normal for certain types of
Right,
discharge.
especially if they're lactating. And all.
Yeah, if they're lactating, breastfeeding, if they're young, if it's coming from both breasts. But there's certain type of nipple discharge if it's clear or bloody, if it's coming from one side.
Just once.
Yeah, like those are definitely, I think any nipple discharge, if there's a question, discuss it with, your provider, your OB-GYN, or your breast surgical oncologist. And we can help, divide and say, is this something that's normal or is this something that warrants more investigation?
Right, yeah. So when they are going to your office, you have checked them, you have some unilateral breast discharge, and on a palpation you don't find too much, not a nodule. So when are you alarmed? When do you send them for mammography?
So any patient that's coming in, I tailor my algorithm a little bit different, or based on age. So patients younger than 30, I might start with an ultrasound first if I'm concerned.
First ultrasound before mammogram?
Yeah,
Okay.
for patients younger than 30.
Okay.
Typically, patients over than 30, I recommend a diagnostic mammogram and ultrasound.
Right, the diagnostic mammogram with the dye injected and see.
So the diagnostic mammogram, they'll just take more specific images in the area of concern.
Okay.
So that's typically what I'll start with for that patient population over 30. And then there's more imaging.
More imaging, right.
Yeah, and it depends on what we find on that initial imaging in the clinical
Yeah, then-
exam.
depending upon what you find initial, if you're suspicious, and then you go for more, right?
Yeah. Yes. Some patients, I recommend getting an MRI if I don't see anything on the mammogram. Some conditions that can cause nipple drainage, I know that the MRI, if we get more imaging, isn't going to change the outcome. It typically is a surgical excision of the duct that's affecting
Right,
the
exactly,
breast.
right, yeah.
Yeah, and I'm a proponent of doing, the least amount of things that we can do to a patient to get the same exact benefit and outcome. That's kind of my practice. So if I don't think the
Right.
MRI is going to change anything, I
Yeah.
don't typically get it
So
unless
no MRI, basically you go about the diagnostic finding in the simple test, and then you go, yeah.
yeah.
So now you know so many treatments are available, Kerry. Uh, what are the advances in diagnosis and treatment?
So I think one major one is 3D mammogram or with tomography.
Yeah. I read about that. You know, it's really very interesting
Yeah.
how you do those tomography.
Yeah, I think it leads to less callbacks for patients and can help detect certain asymmetries or calcifications, things that might not get picked up on your traditional 2D mammography. So it's a fantastic advancement, and I think really has helped a lot of women.
Okay, and then from your expertise, what are the latest surgical techniques?
Yeah, so there's been a lot of interesting things going on. I think broad strokes, patients sometimes when they think about a breast cancer patient that was treated 20 or 30 years ago, they see patients who have had, these radical mastectomies.
Right, yeah.
And have the complications that come with it. If they had
Breast implant, yeah.
Yeah, like if they had lymph nodes taken, the patients might have swelling
Yeah, right.
and lymphedema. What we have done as a surgical community, and there's been large randomized clinical trials to support
Right,
all of us
yeah.
giving this recommendation, but less is more. So we do a lot of breast conservation surgery.
Yeah.
Where we're only doing a lumpectomy, where we're
Very
taking.
lumpectomy, so important for them,
Yeah.
You will do a lumpectomy and put them on the hormones therapy, right?
Yeah, I think so. Especially if a patient's a candidate for it, we obviously wouldn't recommend it to somebody that we think would be more well suited for a mastectomy. From having the additional training as a breast surgical oncologist, because a majority of all of our training is general surgery first.
Okay.
So I'm personally board certified in general surgery and did this additional training. What we learn is oncoplastic techniques.
Oh, okay.
So I think compared to my general surgery training, if a patient had a tumor or mass on the breast, we were making, an incision right over it.
Right, yeah.
That wasn't necessarily cosmetically, appealing. Not that that's
Right.
the primary outcome, but it's still important to women. And so oncoplastic techniques take into account minimally invasive scars, hiding the incision, doing tissue rearrangements to the
Yeah.
breast to give women a really good cosmetic outcome, which is important.
Right, very important for the women, especially middle-aged women. They want to look good.
Yeah, and you want to feel good about yourself.
Yeah. And do you use robotic?
Yes, so that was going to be the next thing I was going to talk about.
That is the thing of today.
So
AI and the robotic
Yes.
surgery.
yeah, I still don't know how I feel about the AI stuff, but yeah. So the institution that I work at, two of my partners are currently enrolled in this trial. I think it's less than 20 centers in the United States that are using robotic assisted surgery to do
Okay.
nipple sparing mastectomies.
Okay.
So what this would entail is patients have an incision that's about less than 3
Less than-
centimeters on the side of the breast. The entire surgery is completed with the robot assisting, and then the surgeon at the console obviously
Okay.
directing the robot. And patients have had, at least the ones that we have had enrolled in our trial, have had excellent outcomes. It's
Okay.
pretty remarkable how far,
How far,
yeah,
how far it
I
can
know.
go.
Yeah.
Oh my God. How everything is advanced, the science had gone so further with all these recent techniques and all
Yes.
that.
Yep.
Yeah.
It was interesting. I gave a talk a couple months ago about, where did we start with breast cancer management and where are we now? And looking back at like the 1500s and 1800s, how
Is that so?
it's especially from a surgical standpoint,
Right,
how
yeah, surgical
aggressive
point of-
we were and how,
Yeah.
again, that tiny incision for women.
Incision, and it is working, yeah.
Yes.
And then I don't want to go through the hormone therapy because that itself is a big,
A huge topic. Yeah.
huge topic, So, but then basically after you do the cosmetic surgery, you follow up on them, right?
Yes.
And you put on them on some medical. Is tamoxifen being used, or is there something better than tamoxifen in Horizon?
Yeah, so when a woman is diagnosed with breast cancer, we look at what receptors
Right, receptors
are affected. And so women that are hormone positive, like estrogen, progesterone positive,
Yeah. Right,
the most common are female hormones that we all have circulating.
right, yeah.
Women who have those receptors positive, we typically would recommend, you might hear endocrine therapy or anti-hormonal therapy.
Anti-hormone. Okay.
Yeah, and that's where the tamoxifen and then there's other
Tamoxifen.
medications like anastrozole
Yeah, the
come
other
into
one
play.
I'm reading more and more about the other one, but
Yeah.
you are the one expertise and you decide.
Yep, and then we make that decision with the medical oncologist too.
Oh, okay.
So
okay.
a multidisciplinary team effort in
Yeah,
terms
yeah.
of
So what
what's
is the
best.
role of multidisciplinary meeting and approach? You get to meet everybody's and their opinion.
Yeah, I think when I trained in general surgery, we didn't do this, and it was such it is so amazing, and it has such, I think, a profound impact on patients' treatment. When I first interacted in one of these meetings, I was like, why do we not do this
Right.
for everybody?
Right.
So what it basically entails is a patient who's coming in for a new breast cancer diagnosis. That's a lot for somebody.
Exactly, yeah. They are already so much upset psychologically and mentally.
Absolutely. It's a lot, and I think how can we reduce the patient, one, having to go to multiple different appointments?
Right, yeah.
This multidisciplinary model, we have the breast surgical oncologist, the medical oncologist, the radiation oncologist, the radiologist, excuse me. We all meet together on the same day, and we go through all the patient's imaging, pathology, everything
Yeah,
from the very
everything,
beginning.
yeah. And then you decide exactly.
Yes, so it's a team effort in terms of what's going to be the best management for this patient.
Right, yeah, yeah.
And the benefit of the patient, too, is they get to see if they would have had 3 or 4 or 5 different appointments before their treatment or at the start of it, it's condensed into one, which can be a lot, but
Right,
the feedback that I've heard from patients is they were so happy that they were able to just get the answer instead of waiting for multiple appointments, not knowing what one physician wanted to do as opposed to another. So definitely a
Right.
team effort, which is great.
So for the patient, it is important to get an opinion from everybody
Yes.
before whatever is being done, whether it is radiation, whether it is chemo.
Yes.
Yeah, it's a big decision
Yeah.
to make. Yeah. Also for you, like a breast oncologist, you have to decide what is best treatment for them.
Yeah, and I think having us all together on the same day deciding the treatment also helps me with what am I going to do for my surgical planning?
Exactly. Yeah.
What surgery is going to be the best for this patient in terms of timing. So
Time, yes.
I think it's fantastic for patients, and it's a model that I hope every patient, if they're diagnosed with breast cancer, that's the way that they're treated.
Yeah, but then can you tell me overall what are the survival rates for this? There are so many graphs there. I looked at it and I was
Yeah.
confused.
So I think, depending on the stage and
Stage of the cancer.
yeah, and whenever I have a new cancer diagnosis, I always start by telling patients
Yeah, the survival.
this is very treatable. The reason being is early detection is key, and most of the time we're having patients come in our office that, this was picked up on a mammogram, it's a low stage, it's a stage 1 or A. You're likely to die from something else or old age than this breast cancer.
Yeah, they can die of something else besides.
Yeah, than the breast cancer. So I can't give you an exact percentage, but early detection, again, it's key. These low stages of breast cancer, 1, 2, even stage 3 breast cancer, it's very treatable and curable, and the survival rate is very, very high.
Yeah, okay. So that's why they have this early awareness of the breast cancer month of October,
Absolutely.
and then somebody suggested to me, Dr. Prasad, give me you should talk about the early awareness. And then I started looking, for you guys, and
Yeah.
then I'm so lucky, privileged to have you about this whole situation.
Thank you.
Yeah, so now what inspires you most about your patient? Fear is something that everybody there, yeah. So when you see them, what is one particular thing, you're looking at your patient, seeing what inspires you?
That's a good question. It's a broad question. And it's honestly unique for each patient, but I truly, the reason why I went into breast surgical oncology
Yeah,
is
what was the reason why you went to that field?
beyond the treatment and the surgeries being something that I've always been passionate about and very interested in. It's always been the patient relationship.
Right.
And that was something I missed in general surgery. Not that you can't accomplish that with general surgery, but a lot of my cases were, an appendectomy, a gallbladder.
Right.
You see a patient post-op one
Sure.
time and then you don't
Sure.
see him again.
Yeah.
With breast cancer, you're maintaining that relationship with the patient, and per NCCN guidelines, following them throughout their initial treatment to survivorship.
Survival, yeah.
I think the thing that inspires me most with patients and seeing them from the very beginning to the end of their treatment, now into survivorship, is how
And
resilient.
their overall treatment, clinical progress, and
Seeing someone from the very
that
beginning.
probably makes you feel good, doesn't it?
Yes, and I think, having somebody come in with, like you said it very well, a lot of fear. I think
Yeah,
the fear is
fear.
the unknown. They
Right.
don't know what's going to happen, and that's our job to help guide them through the unknown,
Right.
to get through the forest and to get to survivorship.
Yeah.
Survivorship, but
Walk through the path of journey, right?
Exactly.
I think I read someplace about.
yeah, and I just think the resilience and I think the grit that I see through the patients I treat and how strong people are and don't realize how strong they are until something like this affects them. I really think it really shows true character and how strong a lot of these women and men can
yeah,
be.
Right, yeah.
Yeah.
So that's good. What would be your last 1 minute keynote advice to our viewers who are watching this today? I know it is
Quick. So
so many things you can
There's so many things
but
I
we
could
have
say.
to wrap up this.
I think get your screening mammogram. You as a patient are your best advocate. Do yourself breast exams. Trust
That
yourself
comes first, right?
Yes.
Self-exam followed by
by mammograms.
mammogram.
Yeah, and then you're your best advocate. Excuse me. Patients are their best advocate. If you think something's off or there's a new change, go see your provider.
Then
Trust yourself.
Okay, trust yourself, see your provider, follow up follow up with them, and then of course you will be following it in your department,
Yes.
in your office as it is. So anyway, no, anybody who wants to learn more about all this, they can always call any major hospitals and on, because all the major hospitals have
Yes.
so they can call and get the whole
Yeah, or go on the website and
Go
search
on.
breast care and
breast care.
Yeah.
Well, Kerry, I thank you so much
you.
for coming to my show today, and because you were so graceful, accepted my invitation
Thank
to
you.
talk about Breast Care Awareness Month. Yeah, and I like to thank our viewers for watching me on my show with my guest speaker, Dr. Caroline Shore. And I'd like to thank our producer for helping me produce this wonderful tape. Until I see all of you again, have a very safe and a wonderful seasons during the holiday. Thank you.
Thank you so much. It's a privilege.